The next topic we're going to discuss are what are called secondary or acquired immune deficiency syndromes. And you have to think of systemic diseases that can increase the likelihood of becoming immunocompromised. And that's what they like to do on exams like the USMLE or homegrown exams. And that is, if you have a disease process, it'll lead to an immunocompromised state. So things like diabetes mellitus, that all aspects of inflammation can be diminished because of multiple mechanisms. One is non-enzymatic glycosylation of important surface molecules. Remember, we talked about adhesion molecules like selectants and integrins, as well as alcohol will be taken up by the cells and be metabolized in polyalcohols like sorbitol, cause an osmotic load where water will come into the cells, disrupt organelle function, as well as the cytoskeleton, and rendering these cells that are critical for the inflammatory process to be non-functional. Another area we talked about in immunopath were the collagen vascular diseases or autoimmune diseases. We talked about that it's a double-edged sword, that your immune system is abnormal to begin with, plus they are treated with immunosuppressive drugs and autoimmune diseases like SLE, so you can be immunocompromised. Another important cause of immunosuppression, especially with the PMNs, is chronic alcoholism, where that alcohol becomes metabolized to acetylacetate and then enters the TCA cycle and produces a lot of NADH and FADH and cause negative feedback, shut down Krebs cycle, beta oxidation of free fatty acids, essentially rendering the neutrophils non-functional. Another important area we have to talk about is transplantation. There are many organs today that are transplanted, including now face transplants, hand and arm and leg transplants. And so the two that they're going to ask about primarily are renal transplant and bone marrow transplantation. Bone marrow, you think of graft versus host disease that we talked about before, which is a hypersensory reaction type 4. We have cytotoxic T8 cells destroying the recipient cells like the keratinocytes in the skin, enterocytes in the small intestine, as well as cells in the liver. So let's talk about renal transplantation. It's a combination of various mechanisms that lead to rejection when you have a renal transplant. Those that get a renal transplant are going to have to receive immunosuppressive drugs, and therefore they become immunocompromised, and this is important because you don't want rejection of the transplanted organ. There are 3 types of rejection, and they're going to be based on morphologic evidence acquired by biopsy material. The first type of rejection is called hyperacute rejection. And when we talk about this is mediated by preformed antibodies that the patient has that are maybe to some other epitope, but it can cross-react and then go to the endothelial cells of the donor kidney, causing a vasculitis, leading to thrombosis and infarction of the kidney. It can also go to the tubular epithelium and cause damage there. You should remember the one structure that is not initially destroyed in rejection, whatever type you call it, is the glomerulus. So that's called hyperacute rejection. The time frame is going to be anywhere between hours to several days after receiving the allograft. And in the time frame that one sees, it can go on to vasculitis, as I talked about, and the second type of rejection is acute rejection. Acute is a time frame anywhere between usually within the first 6 months of receiving the transplant. And essentially what's going to happen at this point is that you're going to destroy, again, blood vessels. You have antibodies, but you also have cytotoxic T8 cells coming in, destroying the tubular epithelium and destroying the interstitium as well, leading to oliguria and azotemia. And again, you would see an inflammatory infiltrate in the vessel wall. That can be PMNs, lymphocytes, as well as in the interstitium lymphocytes, cytotoxic T8 cells coming in and destroying the tubular epithelium. But again, remember the glomeruli are initially spared. And then obviously to mitigate this process, what the clinicians will do from the biopsy information is increase the amount of immunosuppressive drugs to diminish the rejection. Because if the rejection continues, it can go on to the third type of rejection, which we call chronic rejection. When you hear the word chronic in any disease, what you should always remember is at that point is that tissue is being replaced by scar tissue, fibrosis. When you say chronic pancreatitis, definition is fibrosis. When you say cirrhosis of the liver, it's scarring. When you talk about interstitial lung disease, where you have a fibrosing process, it's scarring. So when you hear chronic, you think of a fibrosing process, because remember when we talked about tissue repair, the regenerative capacity is limited in the human body, and so what's going to replace the damaged tissue in organs, in the vast majority of organs, will be fibrosis. So in chronic rejection, as you would anticipate, it's greater usually than 6 months after the initial organ transplantation, and then what's going to happen is as the scarring process is replacing the damaged tubular epithelium of the nephron, the interstitium, as any scar tissue, it'll contract, and then it's going to lead to oliguria, decreased urinary output. And as you destroy the kidney, remember any disease process that destroys the kidney can impair the ability to get rid of sodium. So what's going to happen? You can develop hypertension and azotemia. And what you're going to see microscopically, again, when you hear chronic rejection or chronic blank anything, you always think of fibrosis of the vessels. It can cause constriction, narrowing it, compromising the kidney's vascular flow, leading to atrophy and diminished capacity to carry out the physiologic function of the kidney. And you'll also see occasionally lymphocytes coming in as well in the interstitium. As you know that once you develop scar tissue, it's irreversible, so the prognosis is going to be poor despite continued immunosuppressive treatment, and the patient may require one of two things. They may have to receive a second allograft or be put on renal dialysis. An important acquired immune deficiency state, as you would imagine that's going to be always on the USMLE, is AIDS. And when we talk about acquired immune deficiency syndrome, this is what we have to look at, and it's a great way of looking how the immune system is put together, and then one component, or several components I should say, have now been injured or destroyed, leading to an immunocompromised state, in this case due to the HTLV-3 virus. So what is the diagnosis? How does one arrive at that? Obviously, it's going to be based on the clinical presentation of the patient in terms of opportunistic infections and atypical or aggressive neoplasms. And so by definition today, we clinically look for a CD4 count less than 200 cells per ml, or showing that you have antibodies or the presence of the virus. And so basically, that's how we define AIDS. Now, this definition took place on midnight, January 1st in 1993. Prior to that, it was based on unusual opportunistic infections or persistent tuberculosis, pneumocystis carinii, women getting cervical cancer at a younger age, and Kaposi's sarcoma. These were unusual variants or unusual or atypical opportunistic infections had not seen before. It was first described in Los Angeles in 1981 in 6 gay males. And from that point on, it has gone through the last 28 years trying to understand the disease process. Initially, the mortality rate was nearly 100%, but because in the last 28 years, what has happened is knowledge of the disease has introduced prophylactic therapy at an earlier start of the disease, so that the mortality and morbidity associated with this disease has diminished greatly because of this. So when we talk about the epidemiology of the AIDS virus, you see it more typically in males versus females. However, when you have the most common mode of transmission is going to be in a heterosexual couple is actually the female, because the vagina is permeable to the virus because it's highly vascularized. And it can occur in all ages. It typically has a incidence between 20 to 50 years of age. However, two other groups at the other ends of the AIDS spectrum, or age spectrum, I should say, is obviously when you have increased multiple sexual partners, like in adolescence or in college age individuals. And then you also have to remember the elderly, because since the AIDS virus was first described in the United States, about 10% of all patients who have been diagnosed with AIDS have been the elderly. And so they get it primarily just like the other age groups from sexual contact. Because you got to remember, when you're retired, you're not studying for exams, you don't have to worry about raising children, you may have grandchildren. And so if you think of what state in the United States has the highest rate per capita of AIDS virus, is Florida. So in retirement, you do things that you enjoyed early on in life, you have more time for it now. So just because you're 82 years of age does not mean the feeling is lost. It's still there. You'll find out when you get that age as well. So all areas of the country are affected. One of the highest areas is in the south of the United States. Why? Well, one venereal disease, if you look at the CDC statistics of reportable venereal disease in the United States, is syphilis. And so it mirrors other venereal diseases, so you have to think of that as well. So acquired immune deficiency syndrome, when we talk about transmission, they like to ask about this exam, and clinically it's very important to understand. The most common mode of transmission is sexual contact. They may ask questions like, what form of sexual contact has the highest probability or risk for transmission of AIDS? Is going to be anal intercourse. Why is that the case? Well, you go back to histology and you think of the rectal mucosa. How many cell layers thick is the rectal mucosa? Is only one cell layer thick. So therefore, any type of minor trauma, if you have a pathogen, can now get translocation and then spread. What else can you spread besides AIDS through anal intercourse? Hepatitis A, B, C, syphilis, gonorrhea, other viruses like herpes, CMV. So any type of sexual activity that involves anal intercourse, for example, you can transmit it. Versus vaginal intercourse, when you think of the type of epithelium that's in the vagina, the cervix, the penis, is that it's stratified squamous epithelium, which will be more resistant to minor trauma and less likely for organisms to basically spread. So you think of homosexuals have a high propensity. Obviously, if you practice anal intercourse, it increases without using a condom. It'll increase the likelihood of transmission, and that also obviously would occur with anal intercourse between a male and female. And so the number of partners, if you're a heterosexual couple, obviously in prostitution, they have a very high risk for developing AIDS and transmitting it to multiple partners, so they have to be under constant surveillance. As I mentioned before, there are other venereal diseases that can also be transmitted as cofactors, like herpes as well as syphilis. Another important mode of transmission is parental. And what does that refer to? Is basically needle sticks or IV drug use. And obviously, that sharing needles that are contaminated with many pathogens, including the AIDS virus, it can lead to increased likelihood of transmission. So on exams like the USMLE, if they say there's a 35-year-old man who's an IV drug user, that's a signal to you that there's going to be some opportunistic infection that's taking place, or transmission is going to be increased. In the past, before AIDS virus was actually screened, it has a very interesting history. When you talk about the screening of blood products for the AIDS virus, did not take place until the late 1984, 1985, because initially it was described in 6 gay males, and they thought initially this was a gay disease. So a lot of policy decisions we're making were very biased and prejudicial based on who contracted it. And so what happened was a number of people who required concentrates of plasma, like hemophiliacs requiring factor 8 or 9, would get this contaminated concentrates of factor 8 or 9 and then would develop AIDS virus and die. These would be children dying at a very young age because they were not screening the blood for the AIDS virus at that time. Blood transfusions, again, another blood product, was also seen. Many people getting elective surgery or emergency room, they would get AIDS as well. And what's interesting is once they started screening, the number of blood transfusion related type of AIDS cases diminished, but it wasn't 100%. And the reason is because people didn't realize at the time, for the next 10 to 12 years, that some people do not make antibodies to the AIDS virus. Because a lot of these tests were based on antibodies to the various epitopes of the constituents that make up the AIDS virus. like GP120, GP41, and a protein 21 and so forth. So they didn't actually start screening for the virus itself using PCR until March of 1996-97, and so it hasn't, for the last 12 years, has been screening for the actual virus. And so the number of cases has diminished greatly, and the stringency in terms of screening the blood supply so that the likelihood of the AIDS virus being transmitted has diminished. Now, what they sometimes ask on exams is, what is the likelihood of needle sticks? Let's say you're a healthcare provider, as like a physician or a medical student, and you get a needle stick. The incidence of random needle sticks is about 1 in 1,000 to 1 in 3,000. Obviously, if you work in an AIDS clinic or an AIDS hospital, the rate's going to be much higher. So it depends upon the population you're exposed to and the likelihood of, from a needle stick, getting the AIDS virus. So, hospital workers. The last is vertical transmission. And what I mean by that is basically if you take 100 women who are HIV positive and ask the question, what is the transmission rate of the AIDS virus, and these women have not received any type of medical intervention in terms of antimicrobial agents, is what's going to happen is the transmission rate is roughly 25%. If the women have chorioamnionitis at the same time, the transmission rate will be 50%. But today, over the last decade, women who are HIV positive and pregnant receiving antimicrobial agents, the transmission rate today is less than 1%. Now, the AIDS virus. When we talk about the AIDS virus, it's an enveloped RNA retrovirus. And remember, retroviruses from virology and microbiology have long terminal repeats, or LTRs, at the 5' and 3' ends for insertion into the host genome. Because it's an RNA virus, you have to go through the process of having the enzyme reverse transcriptase to convert it to DNA, so it's able to integrate into the host genome, and we call that the provirus. And this provirus, once it's integrated in the human genome, it can stay in those cells for up to 6 to 7 or 8 decades. So if you wanted to win the Nobel Prize, you develop a drug that could extract it from the host genome, you would get it. And that's what people are trying to figure out, ways of removing the virus from the infected cells. So what are the cells that are infected? Are CD4 positive cells. And what are the two major groups? Obviously, CD4 helper cells, both H1 and H2. And then the other CD4 population, and the virus really won the lotto when it picked the CD4, because all macrophages are CD4 positive and can be infected by the AIDS virus. Why is this critical to remember? Remember, what's the lifespan of a macrophage? 60 to 120 days. So now if you have a long-lived cell that's now infected, this basically becomes the ultimate parasitic factory for production. And because it also, this macrophage will release many cytokines and stimulate and cause the various symptoms and signs that are associated with AIDS virus in human beings. So obviously, what are some lymph node macrophages? We call these follicular dendritic or reticular dendritic cells. They're going to be important for antigen presentation. Langerhans cells, obviously these are macrophages in the skin. And they could think of Kupffer cells in the liver, the intraalveolar pulmonary macrophages, and don't forget in the brain, microglial cells. So all macrophages can be infected by the AIDS virus. How does this virus get inside the cell? There's got to be receptors. Any cell-to-cell interaction requires receptors, and the AIDS virus is no exception. So what the virus, as you recall, has a number of glycoproteins. An important glycoprotein is GP120, which is a cleavage product of GP160. And this GP120 is used by the virus to bind to the CD4 molecule on CD4 positive cells, T helper cells, and all macrophages. Now, there are co-receptors that are also required, as well as the other product of GP160 that gives you GP120 is GP41. What are the co-receptors? Are what are called the chemokine receptors, beta receptor 5 or CCR5, and then CXCR4 or alpha chemokine receptor. Remember, the chemokines are important small polypeptides that are chemotactic to recruit various leukocytes. Now, there's an interesting story that you should remember is how did they discover it was in San Francisco. And how they discovered it here was they noticed that in the population in San Francisco who had the AIDS virus, they would never get AIDS itself, the opportunistic infections or neoplasms like sarcoma. And they couldn't understand why until they looked at these patients carefully at the molecular level and they realized they had either defective or deficient chemokine receptors, and so they would never get AIDS, but they could still transmit the virus. Now, when we talk about AIDS and how we make the diagnosis, obviously it's going to be serology, looking for antibodies, ELISA test, for example. If there's suspicion, the CD4 count will also raise a suspicion if they can't find it's basically negative for antibodies, then they may use PCR and look for the virus itself, Western blot confirmation. So there are all these other tests to confirm and to make sure that the correct diagnosis is made. And so at this point, you want to monitor the patients, and obviously looking at the CD4 count is important because as the CD4 count decreases, it increases the likelihood of opportunistic infections. So the lower it gets, the greater the probability of getting a number of opportunistic infections. And it's also be correlated by the viral load by using PCR to see exactly if the virus is replicating and using those macrophages as nurseries for the virus to replicate and increase its progeny, infect more cells, and cause a further CD4 count decrease. So the treatment, it's a combination of antiviral treatment. They talk about this in microbiology as well as in pharmacology. There's obviously reverse transcriptase inhibitors, because we know that the virus, in order to infect the cell, has to become a provirus, so it needs that reverse transcriptase to go from RNA to DNA. There's protease inhibitors, and prophylaxis is going to be based on the CD4 count. And on the next slide, you'll see this is also included in your syllabus, is a table showing the correlation of your CD4 count to what type of opportunistic infections tend to appear clinically in the patients who are infected with the AIDS virus. So you can see that from 200 to 500, you're going to have oral thrush, KS or Kaposi sarcoma, tuberculosis, herpes zoster, and then around 200 and below, you see the characteristic pneumocystis carinii, pneumonia, and then dementia. And that dementia could be associated obviously with the microglial cells being infected with the AIDS virus and releasing a lot of cytokines and causing damage or alteration to the neurons in the cerebral cortex, leading clinically to dementia. And you can see as the CD4 count gets even lower, toxoplasmosis, cryptococcus, cryptosporidiosis are going to increase, and then ultimately when it's at a very, very low level, like less than 50 cells per ml, you worry about cytomegalo-inclusion disease, Mycobacterium avium complex, and the JC virus infecting oligodendrocytes, producing the disease, as you recall, progressive multifocal leukoencephalopathy. But today, what are people doing is they're not waiting till the patient has a CD4 count of 200, they're actually treating them with prophylaxis at 350, 400, because they have the virus. It's just a question now to decrease the morbidity and mortality associated with these opportunistic infections. So there are basically two phases clinically to the disease. The acute phase, where you have the initial infection, and depending upon the immunologic status of the host, how the host responds to it, you'll get a viremia with a reduction of CD4 count at this time. And then the patient clinically will have a generalized lymphadenopathy, and the patient will have malaise and fatigue, characteristic of another viral infection like mononucleosis, where basically you get the same type of symptomatology. And this is again during the seroconversion period. Then the latent phase, which can now be months or years later, is that the patient may be asymptomatic or there may be persistent lymphadenopathy. Why is the lymphadenopathy critical to remember? Is that the lymph nodes is basically the incubators for the virus, because we have a number of antigen-presenting cells, macrophages, that are now allowed to replicate. The virus is replicating these cells, and so it's constantly stimulating the lymph node by antigens from the virus, and therefore, as well as cytokines being released that are mitogenic, leading to persistent lymphadenopathy. Then, obviously, these act as reservoir sites for the virus. And again, remember, the macrophage lives 60 to 120 days, and the virus picked the right cell to raise its progeny in. And depending upon the amount of virus you can monitor, in the latent phase, the virus can be at very low levels, and they're basically inserted into the host genome as provirus. And then in the latter course of the disease, close to the terminal end, you get a second typical viremia, and then more upstream infections, and so, or the patient may develop or present with initially as well with basically neoplasias. And we'll talk about the AIDS-associated neoplasias in a moment. In the latent phase, you may find some minor upstream infections like oral thrush or herpes zoster. Now, the acquired immune syndrome, when you talk about progression to AIDS, basically, again, it's a CD4 count less than 200. Again, you're going to think of opportunistic infections. Now, what's unique about AIDS that you always have to remember, compared to other people who have infections, is that in the immunocompetent host, that in an AIDS patient, you get polymicrobial infections, that you can have more than one infection at the same time. And that's an important thing you have to remember. And so you may, again, as I mentioned before, you may get a second viremia in the terminal phase as the disease progresses. Information of this virus is going to take decades to now see how people, if they acquire it when they're a teenager and they do survive for years to come, what the effects of the drugs they're taking and what other diseases that they may acquire that may modulate or affect the AIDS virus in terms of progression of the disease is still unknown. And so as you're going into medical practice, you're going to see the evolution of the AIDS virus. When I was a medical student is when the AIDS virus first emerged and people became cognizant of this virus, and that's where all the research and all the therapeutic interventions have taken place. As an autopsy pathologist, I've done autopsies on AIDS patients, I've treated them, so I've seen the whole spectrum of changes in terms of AIDS treatment and the morbidities and mortalities associated with it. And so we get these AIDS-defining diseases we just mentioned, and then death can occur, but the likelihood of dying of AIDS today is less likely, especially those individuals who are receiving antimicrobial agents. Obviously, those who do not, then the mortality rate is going to be higher. Now, what about neoplasias that can be associated with AIDS virus? One is called hairy leukoplakia, leuko meaning what? White. So this is in the oral cavity, and what virus you always have to think about that is in this immunosuppressive state due to AIDS virus is EBV. It likes to infect epithelial cells like the squamous cells, stratified squamous epithelium of your tongue, for example, where you get this proliferation. And as the squamous cells proliferate, it'll give you this plaque-like structure on the surface. And it's basically the squamous cells losing regulation because of being infected by the EBV virus. Remember, EBV also will infect B cells, leading to EBV-positive B-cell lymphomas or non-Hodgkin's lymphomas. KS, or Kaposi sarcoma, is the most common virus in terms of leading to neoplasia. This is the most common neoplasia you'll find in AIDS patients, as well as others who are immunosuppressed and have the virus as HHV8, or Kaposi sarcoma-associated herpes virus. And it's common in homosexual males. It's sexually transmitted. It can be found in the semen. And again, the virus name is HHV8. And because it likes to infect what cells? Endothelial cells of vascular structures, particularly lymphatic endothelial cells, that you can see the skin, GI tract, lymph nodes, and lung that are highly vascularized, that has a lot of lymphatics, will be infected. That's why you won't see, for example, the brain. You won't see primary KS in the brain because there are no lymphatics. Can KS in rare cases, aggressive cases, go to the brain, yes, but it's going to be metastatic KS rather than arising within the KS. So knowing the normal histology of different parts of the body, different organs, become critical in understanding why diseases occur in certain areas and not in others. And so that's how they're going to ask questions on the USMLE, to make you think about the process and not just memorize it. When we talk about other neoplastic processes, about 6 to 8% of patients who have the AIDS virus or develop AIDS have to worry about developing lymphocytic neoplasms. And obviously non-Hodgkin's lymphoma, the majority of these are B cells, and they tend to be high grade and very aggressive compared to you and I as immunocompetent hosts who get non-Hodgkin lymphoma. It tends to be less aggressive compared to the patient who has AIDS and acquires these types of high grade B cell lymphomas. Remember that non-Hodgkin lymphomas tend to be extranodal. What do I mean by that? It could be in the brain. So if you have a patient who's 35 years old who has primary brain lymphoma, you always have to think of AIDS first. Because when you talk about you and I, brain tumors are rare to begin with. But when you talk about lymphomas of the brain, in you and I, the age is in the elder years, 70, 80, 60-year-olds, not in the 35. Other extranodal sites, you think of the GI tract, the stomach, and in males, the testicle. And so these are extranodal sites that you always have to think about for non-Hodgkin lymphoma. Obviously, Hodgkin's disease can be more aggressive, where you're looking for the Reed-Sternberg cell to make the diagnosis of Hodgkin's disease, and they tend to be more aggressive in AIDS patients. Remember that Hodgkin's disease overall is curable in the immunocompetent hosts, but not in immunocompromised. They tend to be more aggressive, and the stage is a lot higher in patients who have AIDS and Hodgkin's disease. Another important cancer that can arise in women, because of the immunosuppressive state, is cervical cancer. Most cervical cancers are going to be due to human papillomavirus, as you recall, 16, 18, 31, 33. And so remember that when you have AIDS virus, it's sexually transmitted, you're going to also transmit other sexually transmitted infections or diseases, and obviously HPV is the most common sexually transmitted organism today, so it makes sense why you would see a propensity for a higher rate of cervical cancer in women who have the AIDS virus. Another consequence of the AIDS virus is HIV wasting syndrome, and what they refer to is, since the AIDS virus infects the macrophage, and we know the macrophage does what three functions? Phagocytosis, antigen presentation, and the third, it secretes over 150 different molecules, cytokines, including TNF, which used to be called cachexin. And basically, it's a appetite suppressant. So basically, you're going to become emaciated or wasted. And so you get what is a wasting syndrome. Another important thing is it can lead to glomerular damage to the kidney. And the most common glomerular lesion associated with the AIDS patient is focal segmental glomerular sclerosis. So focal, remember, means what? A few glomeruli are affected in the kidney, but a segment of the glomerulus, those glomerular capillary loops, are being sclerosed or fibrosed down. Why? No one really knows. It may be related to cytokines being released by the mesangial cells and stimulating the production of more mesangial matrix and scarring process or fibrosis, hence the word sclerosis. Again, we mentioned that you can get dementia from the AIDS virus once it infects the macrophage or microglial cells, and they can release those cytokines and then cause perturbation to neuronal function, especially those that involving the cerebral cortex, leading to dementia. Here is a table from your syllabus to illustrate the various opportunistic infections. These are not to be memorized, but to illustrate that you can see patients can have at the same time pneumocystis carinii in the lungs, tuberculosis in the lungs, as well as MAI, and cocci, and histo. Remember, what they like on the USMLE is, remember, these organisms live in different parts of the United States, so you get a geography lesson when they start giving you the places in the United States. So obviously, coccidioidosis would be an AIDS patient living in the Southwest or the San Joaquin Valley in California, versus histoplasmosis is somebody who's either traveled or lived in the Mississippi-Ohio Valley region of the United States. Other opportunistic infections are going to be parasites, viruses, and fungi. because remember, what cells are going to control these infections are T cells. Since T cells are being destroyed by the AIDS virus, you can see why it's almost like analogous to DeGeorge syndrome, where you're destroying T cells because of the congenital absence of the thymus. And so you can see these other type of organisms, Giardia lambda, Cryptosporidium, herpes simplex, Candida. These are all examples of fungi and viruses. Other fungi and parasites, Aspergillus is ubiquitous in the environment. In San Francisco on a foggy day, the spore rate goes up, and so your macrophages in your lungs typically will ingest and destroy them. But if you're immunocompromised, like in AIDS patients, you increase the risk of getting aspergillosis. Toxoplasmosis is the most common opportunistic infection in AIDS patients in the brain, leading to necrosis of the brain parenchyma. Cryptococcus is the most common cause of chronic fungal meningitis in the AIDS patients, and it's a chronic meningitis versus organisms like E. coli, Streptococcus pneumonia that tend to be a purulent or acute bacterial meningitis. And as I mentioned before, the JC virus basically likes to infect what cell of tropism is the oligodendrocyte, leading to the disease of progressive multifocal leukoencephalopathy. Since it affects oligodendrocytes, what cranial nerve, as you recall, is an extension of white matter of the 12 cranial nerves, is the optic nerve. So they often will have visual defects or problems because of the destruction or demyelinization. What's another disease that likes to destroy oligodendrocytes is multiple sclerosis. They also have visual effects or deficits because of this.